So our very first speaker, and I'd like to introduce, just bear with me, Dr. Simone Tanguay. Dr. Simone Tanguay is a professor and chair of the Division of Urology at the McGill University Health Centre and McGill University. He is actively involved in the Kidney Cancer Research Network of Canada since its creation, and also the development of the Canadian Kidney Cancer Information System, which we fondly refer to as CKIS. He was a supporter of Kidney Cancer Canada since its creation, and his research interests are focused on diagnostic and therapeutic strategies for kidney cancer. He also served as General Secretary and President of the I'm going to say this wrong, I apologize, Society International Urology. And this scientific society has a mission to enable urologists from all countries to apply the highest standards of urological care to their patients. It also has an important philanthropic role to train urologists in developing countries. So I've actually heard some of the stories that Dr. Tanguay has shared with us, and they really are truly amazing, and we are quite blessed in Canada. As I'm sure Dr. Tanguay will assess from some of his stories how difficult treating kidney cancer can be in global countries. And I'd also like to acknowledge that Dr. Simone Tanguay is the chair of our medical advisory board, which we hold in high regard. They're there for us when we have questions. They keep us on track to make sure that our information is medically accurate and beneficial to our patients. So they play an invaluable role in our organization. So without further ado, I'd like to introduce Dr. Simone Tanguay, who's going to speak to management of localized kidney cancer. Welcome, Dr. Tanguay.
Thank you, Kristen. Thank you, Marion, and thank you, everybody, for the opportunity to be with you today. So I was asked to talk a little bit about the management of localized kidney cancer. Obviously, in itself, it's quite a large topic. So what I'm going to say is a bit superficial view of the management. I'd be happy to take, any questions after, obviously. So just a little bit of outline of what we're going to talk in the next, 20, 25 minutes, a little bit about statistics of cancer and kidney cancer. How do we stage kidney cancer? Because this is probably the first step and an important step in making the decision of what's best for you after, and then the different treatment option. We've heard about surgery. We've heard already about active surveillance that can be quite prolonged in time. So we'll discuss a little bit about that, and then talk a little bit about the different surgical options and the technology we use to do these surgeries. So when you face cancer, the sad news is you're not alone. It's a good and a bad news. These are the statistics, the predicted statistics for 2025 in Canada. You can see that we expect that over 250,000 Canadians will face a diagnosis of cancer this year. That represents 2 in 5 Canadians that will face cancer in their lifetime. So there's nobody that doesn't have a history that relates to a family member, a close friend that's facing cancer. So it's really something that is there for all of us. You can see on the right panel the distribution of the cancer in general across the country. And obviously the darker color represents the more frequent diagnosis of cancer. And it goes also along with the size of the population in the different provinces. Kidney cancer is the same. You can see that this is the impression of kidney cancer. So in Quebec, where I work, it's about 2,500 patients per year, and it varies from province to province. So it is certainly an important part of our practice. What does it represent compared to other cancers? So it's a cancer that's more common in men than women. Represent 4.6% of all cancer diagnosed in men, with prostate being the most frequent, and 2.5% of all cancer diagnosed in women, with obviously breast being the more common. So it gives you an idea of how frequent is this diagnosis. So whenever we face a diagnosis of a cancer, it presents most of the time as the finding of a mass in the kidney. either because we've had symptoms like bleeding, which is probably the most common, bleeding in the urine, or we've had the ultrasound or other form of imaging for other reason, and we find that there's a mass in the kidney, sorry. The first thing we do is what we call staging. We need to know what's the local extent of the cancer, and that's done through imaging. Most commonly, we'll do CT scan or MRI of the abdomen, and then we'll do CT scan or chest X-ray for the lungs. And why we always look at the lung is because kidney cancer, when it's spread, its number one target is in the lung. So for anybody that was diagnosed with kidney cancer, we constantly monitor their lung for that reason. And you can see there's two staging systems that we use. There's the stage 1, 2, 3, 4, which I think most people are most familiar with that. The smaller the number, obviously, the more localized the disease is. Majority of our patients are stage 1, meaning a mass less than 7 centimeter. And basically, the stage 1, 2, 3 are commonly treated locally, either surgery or other technique that we're going to discuss. And the stage 4, when the disease is more advanced and has touched other organ, classically, the first line of treatment is to use systemic treatment. There's also another staging system that, as physician, is probably the one we use the most commonly. It's called the TNM system. And the TNM system represent T for tumor, so it's the extent of the tumor within your kidney. N refers to lymph node, are the lymph nodes involved or not? And M represent metastasis to other organ. Is your lung involved, as I was mentioning, as it spread to the adrenal gland, your liver, and what have you. So the TNM system is what we often use. There's two forms of staging. One is clinical. This is based at the presentation on the X-ray that we do. And the second one, for those who have surgery, is pathological. And the pathological really represent what the pathologist under the microscope see as the extent. And this is probably the most accurate to predict what will be after for you, in your journey. There's often confusion between stage and grade. They're very different. The stage is the local extent, and the grade is the aggressivity level. The grade is based on looking under the microscope at the tumor and telling us, is it an aggressive tumor or a non-aggressive tumor? And in the form of kidney cancer, it goes from 1 to 4, 1 and 2 being less aggressive, 3 and 4 being more aggressive. So there's a big distinction to make between stage and grade, and it's very important for what we're going to do after. Now, obviously, the higher the stage, the more important is the disease, and the more important is the treatment you're going to receive. Not that it's not important at stage 1, but the likelihood to require more than one form of treatment, being systemic treatment plus surgery or radiation, increase as the stage increase. So there's a direct correlation between the control of the cancer, the ability to control the cancer is much better and easier in a lower stage than in higher stage, which makes sense. Now, for most cancer, the first step is to confirm the diagnosis with a needle biopsy. Interestingly, for kidney cancer, we don't always do that. It's a step that sometimes is just adding procedure and morbidity or discomfort to the patient without changing what we're going to do. Because if there's a large mass in your kidney, it still has to be removed. So we don't do the step of the biopsy first. When do we do a biopsy? Well, we do a biopsy when we need to confirm the diagnosis. For example, if you have a very small mass, we'd like to know because up to 20% of these small mass can be benign. We will do it when it will influence the decision on what we're going to do. I think we're going to talk in a minute about active surveillance. It's certainly an area where the biopsy is very helpful. Most of the time, it will be done relatively easily, either with ultrasound or CT scan. The radiologists are the one doing that. And one area or one situation where it always needs to be done is in patients that present and their disease already spread to other organs, or we need to confirm the diagnosis in these patients to make sure we select the best treatment for them. Now, like the cars, cars are not the same. They bring us from point A to point B, but they all have their particularity. It is the same for kidney cancer. All kidney cancer are not the same. There's the most common ones, what we call clear cell or conventional. Then you have the papillary, the chromophobe, and then you have a series of less common form of cancer. And this list of less common form of cancer is rapidly growing, actually, because we refine our ability to diagnose and understand the molecular aspect of the cancer. And we have a growing list of diagnoses that just 10 years ago existed, but were just not recognized because of the ability we have. Now let's talk about active surveillance. It's a good option. It's like, first thing is people will say, why do we want to watch a cancer? Well, I think we've heard from Christine that sometimes it may be a good option. It may save you procedure, potential complication. So normally the active surveillance is reserved for patients with small renal mass, most commonly less than 3 centimeter. We do that because they tend to grow extremely slowly. Some of them like an average of 2 millimeter per year. The risk to spread to other organs is extremely low. And we have some triggers that we use in the follow-up of the patients, either the rapidity of growth or once we reach a certain size, that's when we decide, if we want to go ahead and go for a treatment. Originally, it was proposed mostly in older patients, knowing that many of them will never need treatment for their kidney cancer. However, today it is used more and more, even in the younger patients with facing a renal mass. For example, in our Canadian guidelines for a mass of 2 centimeter and less, active surveillance is viewed as a prime option for these patients. It is, however, in my book, a patient when they're younger, that the biopsy would be helpful to make sure that we don't face a very rare or more aggressive form of kidney cancer. Now, if we talk about surgery, there's multiple options. Should we remove the whole kidney, only part of the kidney? Now, we know that a large proportion of our patients with kidney cancer are found incidentally. These masses are smaller and smaller at the time of diagnosis. So it is clear that we don't always need to remove the whole kidney. The factors we consider in making our decision is the size of the mass, where it's located within your kidney, how complex it is to remove this mass. And then we also use the history of the patient, your medical history. If you have chronic renal failure, if you have disease like diabetes and hypertension that may affect your kidney function, we want to preserve as much as your kidney as possible to make sure that our surgery will not push you or accelerate the need for dialysis, for example, which is life-changing. Now, it's important to know that whether we remove the whole kidney or just part of your kidney with a mass, it does not affect the cancer outcome unless the mass is very large, in which case we don't tend to do partial nephrectomy. Now, there's multiple ways to do that. The conventional one is an open surgery where we make an incision and we go identify the mass inside of your kidney. The kidney is what filters our blood, so we stop the blood flow in your kidney temporarily, and we go and basically remove this mass and then repair the inside of your kidney and close the kidney together. So often we can save the large majority of your kidney by doing that. It can also be done by laparoscopy. The laparoscopy is an approach where we put a little entry site in the abdomen. We inflate the abdomen with gas and we can see inside, and we use instrument and work from a distance. And we do actually the same surgery as open, except from a distance. It's a surgery that many urologists have developed the ability to do. However, it's technically challenging in laparoscopy. And this was greatly, I would say, improved with the increasing use of robotic surgery. Robotic surgery is a fancier way of doing the same surgery. So we have the same entry port in the abdomen, but your surgeon, instead of holding the instrument himself, works at the console, in the corner of the room. And the benefit of robotic surgery is that a lot more liberty of movement. The repair and suturing are much easier. The ability to train people to do these surgeries is much greater. So it has pushed the ability of centers to save kidney rather than removing them. So it's really a great tool. The limitation is it's not available in every center. In Canada, I can talk for Quebec. All of the robots that exist in Quebec are philanthropic of purchase. So there is a limitation there. However, Da Vinci, which was Intuitive Surgical, which was the only company we had with robotic surgery for many years, now has competition. There's a second brand of robot that's approved and in use in Canada currently. There's a number of new robots that are coming on the market. There's very competitive and very good robots from India, from China, for example, that will come and drive the price down of this technology and make it more readily available for more center. Now, surgeons, we like gadget, we like tools. This is certainly a very attractive tool for urologists and all surgeons, but it does not stop there. If you look now, I don't think this technology is in any Canadian center to my knowledge now, but it's very much in use in the United States. Have you seen on the previous slide, there's about 4 or 5 entry sites, to do this surgery. Well, this robot has only one site of entry. You can see this is the one site, and within there, you have the camera, you have your 3 instruments, and you can go and do surgery in much limited space, more difficult space to reach. This will be a new tech. This is already a new technology that allows to do things that we could not do in the past, and this technology just keep improving very, very, very rapidly, which is very exciting for the surgeons. Obviously, we like these, but also for the patients because it allows us to do things that we could not do in the past. What we see also with surgical development is now we have the ability to do 3D reconstruction. We can give the roadmap to the surgeons, about all the vessel, the intricacy of the vessel branching inside of the kidney, so that when we go and remove a mass, there's no surprise along the way. You know exactly where you're going. It's like seeing the roadmap before taking on a trip. So this is very much present now. We can rebuild a 3D model with 3D printing that you can have. You can show your patients. It's not readily used in most centers because of cost, but it's there. It's already developing very fast. And what we see now is that these 3D reconstruction and the use of artificial intelligence allow to merge these images in real time for the surgeon during robotic surgery. The artificial intelligence allows to recognize the organs, and they will give you these drawing of the vessels, for example, so that there's no surprise of finding a vessel where you were not expecting it. You have this superposition of the image that move with your robot. So technology is going extremely fast, and I think it will just improve the quality of the surgery we can offer our patients in the future. So as you can see, for partial nephrectomy, there's multiple surgical options. How do we make a decision? It's often the surgeon's choice, often the complexity of the resection and the reconstruction. Sometimes it's best to be done by open surgery. Sometimes it's been done by robotic surgery. It also depends on the availability of the technology and the expertise of your surgeon. I think in many centers and in many provinces, I can speak for Quebec, it's not unusual that patients are transferred from surgeon to surgeon or center to center just because you know that this center can do something that you cannot, and you want to make sure that your patients benefit from that. Now, if we go to the other options, if we don't want to remove the tumor, we can destroy it by a different form of energy. I would say there's 3 main one currently. There's more than that, but just to make it simple, there's 2 forms of tumor ablation by energy that are available in large majority of centers across Canada. One is what we call radiofrequency ablation. There's different tools. Basically, it's like a little umbrella that you deploy inside of the mass and you heat it to destroy the mass by the heat. Or the opposite, this is a picture of a kidney tumor during laparoscopy. Most of those now are done through the skin with no surgery, but we can freeze this mass. So you can see the white is an ice ball actually, and we can freeze the mass to destroy it by the cold. This technology works well for very small mass, 2-3 centimeter. It can be done with larger mass, but with less success. So most of the time, it's reserved for mass of 2-3 centimeters for patients that don't want or cannot have surgery. These are great alternatives. I would say the new kid on the block is high dose radiation ablation. So we can use now radiotherapy that would deliver at a very high dose on the renal tumor, and basically we stop its growth and we prevent it to continue to grow and potentially give problem to patients. It's relatively new. It's using more and more. Its use is very limited to a small subset of patients until we acquire more knowledge about it, and also that we have longer follow-up of these patients to make sure that on long term the efficacy is there. Now, when do we remove the entire kidney? So, as I mentioned, if we can preserve the kidney, we always do that. But sometimes the mass is too big, and sometimes it's just not possible because of the location. So this is the same thing. These surgery can be done by open surgery, can be done by laparoscopic surgery, can be done by robotic surgery. All of the options are there. And what we do when we remove the entire kidney is basically we go and attach the vessel that feed it. We attach the ureter, which is the drainage tube for the urine that comes to the bladder, and we remove the entire kidney that way. It can be done, obviously, with laparoscopy. It's probably the number one way of doing this surgery for the not too large renal mass in Canada. And basically, what we do is once the kidney is detached, we place it in a bag, actually. We extend a little bit the incision, and we are able to remove the kidney as an intact organ within that bag. And that allows the pathologist to have a proper assessment of the extent of that tumor. Kidney cancer is also a cancer that has one particularity, which is that the tumor can grow and extend inside of the venous system. So we have a main vein in our body that's called vena cava that brings the blood from our feet to our heart. And the tumor can grow inside of this, and it can grow actually to different level up to inside of the heart sometimes. So this is a good example where the staging, the initial CT scan and MRI are very important to recognize this type of pathology, because the surgery, as you can imagine, is a bit more complex, and most of the time it's done by open surgery, although some of these tumors now are done by robotic surgery in very specific centers that have developed this expertise, but by and large it's done by open surgery. And you can see that the complexity of this is that we need to isolate the entire blood flow, because this is what brings all our blood to our heart. So you can imagine that we cannot make an opening in that main vessel without severe hemorrhage. So we have to isolate very temporarily to remove the entire tumor with that extension that goes inside of the vein and close that back. So obviously this is a higher stage, as we discussed before, and the higher stage comes with a higher risk of seeing this tumor come back in the future. But this is one example where radical nephrectomy is essential. Now you'll hear after me about the after surgery. How do we prepare for surgery? I think every center probably have their way of doing that. Just showing you example in my center, our patients all go through what we call the preoperative clinic. They see the medical team to make sure that they're fit for their surgery. They see the anesthesiologist, nursing, and they also get this booklet, a guide to kidney surgery. You can find that on the web at the MUHC, but basically we lay out to patient as much information as possible of what to expect, where to call, what to drink and eat the day before, the day of their surgery. And for every day after the surgery, because of our ERAS protocol, like early recovery protocol, there's goals that patients, they know ahead of time what to expect and what we expect from them, so that their journey is on track. So this is the way we plan for surgery in our center, and you'll hear after me in other center how it's done, but I think it's relatively similar across centers. Now, we mentioned at the beginning, when we get the diagnosis of kidney cancer and we remove it, then The pathologist will assess the tumor and will give us the staging of the tumor. And that's where we have what's called the pathological stage. So that's the true extent of your tumor. And then based on that, we will determine what kind of follow-up you need. So patients with less risk of coming back don't have to have such an intense follow-up, and patients at higher risk of coming back have a more intense follow-up with blood tests, CT scan, and so on and so forth. And this is the guideline we have in Canada, allowing us to determine how we're going to follow patients. And obviously, this is adapted for everybody. Eh? So some people are comfortable, not comfortable with the follow-up, and we adjust so that everybody has a safe and not too strenuous follow-up. Last thing is, can we offer something more after surgery? If you fall in a category of patients that have a high risk that the tumor come back in the future, our choice is to follow you and make sure it never comes back, obviously. But if it does, then treat you at that time, or we can give you treatment to prevent reoccurrence. There's a number of treatment over the years that were tried and tested. Most of them failed to demonstrate the benefit. We now have one immunotherapy drug that's approved and used and reimbursed in all provinces of Canada, pembrolizumab. And this is, your doctor may talk to you about this if you qualify for the benefit. There's always pro and cons to everything, but this could be a discussion you have after your surgery. What's very exciting in the last month, there's two other combination of drug that demonstrate an early benefit. And we have to wait that these studies mature to make sure that this benefit holds in time. But there's potentially other options that come down the road for the prevention of reoccurrence after surgery. And I welcome you to look, on the Kidney Cancer Canada website. You have this document, which is a decision aid created for patients that face that decision. It's both in French and English, and it helps you to reflect at home about the discussion that took place and make your informed decision. Now, just to finish, as you've seen for localized kidney cancer, there's multiple options. Obviously, there's not one that fits all. You've already heard that from the introduction remarks. Each situation is different, and we adapt to that. Obviously, what will affect that is also the expertise of the surgeon and the center, which I think are important. And most importantly, I think it's important to be informed. We heard about the Google doctor, when at the beginning in the remarks. I think it's normal to be informed. I think you can go on the Kidney Cancer Canada website. There's a lot of information that's validated, and there's a number of sites like KCC where you can get very good information. Ask questions. Very important to be knowledgeable about what you're facing. And most importantly is you be comfortable with your choice. When there's multiple choices, it's always difficult to know, is it the right one? But once you make, I always say the same thing to my patients. Once you make your decision, this is the best one for you, you go for it and you don't look back. This is the choice you've made. So this is a little bit of an overview of treatment of localized kidney cancer, and I'll be happy to take any question you may have. Thank you.
Thank you so much, Simon. That was a really informative presentation and very helpful, I think, to our patients that are newly diagnosed and possibly facing surgery. And it kind of answers questions sometimes for those that have already had their surgery. I know that we're probably going to be talking about, some post and preoperative care coming up, but maybe you could just, as a surgeon, pass on how important it is to give your body time to recover. We continue, I'm sure you see this a lot, that people don't realize how much time it takes. Could you just speak to that, please?
Yeah, thank you. I think it's a very, very good question. And I think it starts in our office, when we see people get out their agenda to try to find a day where the surgery can fit. I always say the same thing, is that it doesn't fit anywhere, So the first thing is, it's like anything in life, you have to put priority, and this has become your number one priority. Maybe if you have a very small mass that's not very, aggressive and pressing to deal with, you can try to find a time that suits you. If you would fit active surveillance and you decide that you do that in 2-3 months, I think it makes sense. But Otherwise, you don't try to dictate, put that as a priority. This is number one priority in your life at that time. That would be my number one. After surgery, I always say the same thing. Take the time to fully recover. Patients often feel early after a surgery that they've recovered, especially now that we do minimally invasive surgery. Patients often stay overnight in the hospital and there's no big incision, so they feel they had a small surgery when the impact on their body and the psychological impact are major. Take the time to fully recover before you embark in your normal life after, because sometimes it's difficult to pull back, if you've been back to work too fast. Take the time.
Okay, that's great advice. Thank you. Another thing that we often get is patients write in and say, well, I've seen my surgeon, and when do I see my oncologist? And basically, their only treatment would be surgery. So maybe you could just touch on that you don't necessarily have a transition.
That's a very good question, because most cancer patients will see oncologists. So for the treatment of localized kidney cancer, until recently, where we have the opportunity to give a preventive treatment, there's most of the time there's no benefit to. Sorry, my dog is giving me a visit right now. So very often there's no need for the medical oncologist to get involved, because it's not a disease they see and they treat early on. I think if you fit the criteria to qualify for more treatment after, then I think we always welcome the conversation with the medical oncologist to make your most informed decision. Other than that, the urologist will do your follow-up, and if need be, at some point, that you require the help of the oncologist, then we'll send you back to them. Right. What we try to avoid is have two doctors look at you for the same reason, and then sometimes there's duplication of visit, duplication of test. At the beginning, is viewed as a safety net for most patients. But on long term, it's not helping you. It's duplication.
Right. And that's kind of that Dr. Google thing we talked about when we have localized patients that look with Dr. Google and they say, okay, well, they go way down the road that they don't even need to travel. So, just take a breath, deal with what you're dealing with right then. And then if you need to, your urologist will forward you to the oncologist.
Absolutely.
Right? I think we have a question from our audience, and at what stage kind of fits with what we talked about, at what stage and or grade should patients be referred to an oncologist?
So currently, for the use of preventive immunotherapy after surgery, it's very well defined. It's very well defined, the stage and grade and the characteristic of the type of tumor. First of all, it relates to patients with the most common form of kidney cancer, which is clear cell or conventional. So if you have a papillary tumor, if you have a chromophobe tumor, you don't qualify for this treatment, not because we exclude you, but because it's not been demonstrated to be beneficial. And until we have proof of benefit, we don't want to give treatment that will not benefit you, because there's nothing we do that's without consequence. Everything has potential side effect, and some of them can be important. And then it's very clear. So for example, if you have the localized smaller tumor, the PT2, if you're a very high grade 4, or if you have a variant that's called sarcomatoid, then you qualify for this treatment. If you have PT3 disease, then you qualify for it automatically, and so on and so forth. So, but this is very well defined. All urologists and medical oncologists are very aware, and we cannot go outside of this. Otherwise, the treatment has not been demonstrated to be beneficial, and it's not reimbursed.
Understood. Well, that's good information. Thank you. I invite anyone in our audience that thinks of a question after. You can send any questions to us at info@kidneycancercanada.ca. If you type it in the chat or the question and answer after, we'll make note of it and make sure that Dr. Tanguay has an opportunity to answer. And I thank everybody. I thank you for this excellent presentation. And I think I even learned something in this one too. So thank you so much.
Thank you for the invitation. My pleasure.
Thanks.